It's just a huge honor for me today to be podcast interviewing Dr. Marco Antonio Brindis, all the way from New Orleans. He's a full-time faculty in the Department of Prosthodontics at LSU School of Dentistry, where he maintains an intramural restorative practice devoted to aesthetics and implants with an interdisciplinary approach. He earned a DDS from the Universidad Intercontinental in Mexico City in 1998. He did a preceptorship in dental implants at the Universidad Intercontinental in 1999, and a preceptorship in dental implants at the dental school at the UT Health Science Center in San Antonio in 2002. He completed a surgical implant fellowship at the Biotechnology Institute in Vitoria, Spain in 2003. He got a certificate in prosthodontics at LSU School of Dentistry in the Department of Prosthodontics in 2007. He then completed all the Esthetic and Occlusion courses at the Pankey Institute in 2007. Dr. Brindis is very passionate in the field of interdisciplinary dentistry for full mouth reconstruction, aesthetics, and implant dentistry. Also, he is involved in the development of new implant protocols to treat the edentulous patient. He has lectured in the United States, Mexico, Canada, and Spain. He is a member of several organizations, including the American Academy of Restorative Dentistry, Academy of Osseointegration, American Dental Association, American College of Prosthodontics, and the Pierre Fichard Academy. Man, thank you so much for coming on the show today.
Oh, thank you very much for inviting me. Really, it's an honor to be here with you today.
You know, a lot of people say that your success rate of dental implants for your first 100, you know, the failure rate is twice as high as the first 100 as it is in the second 100. I know a lot of dentists my age that are like, 55, who hired some young associate. They started taking some weekend warrior implant cases, placed a bunch of implants, and then, associates only last on average 2 years is considered good in corporate dentistry or private practice. And then that dentist leaves and goes away or another state, and then this dentist is eating these implant failure cases and sending him to, periodontist and having to pay out of pocket to have the whole damn thing redone. I know one guy who's had to pay for 7 implant cases to be redone at the periodontist. What are your thoughts on that?
Well, I have to say, you're absolutely right. My most successful hybrid implant supported case that I have done in my life, it was back in 2002 when I placed my implants myself, and I did the loading myself, and needle loading and everything. And that's the most successful one because I moved to New Orleans in 2004. So I didn't get to see all the failures after and all the complications after. So that's what we call the geographical success. And it is true. And that's why so many times people tend to say, like, no, I have really good success on my implants and everything, and it's because they don't have the follow-up, So definitely, it happens to me in my first year. Perhaps I have 100 and something implants, and I didn't have any failure. But then I move out, and then I never got to see my mistakes. I happens to see on the case that I did after the couple of thousands of cases that I have done after, that's when I have seen all the failures and all the complications. So you're absolutely right. It's just a matter of time until you start seeing something going on, prosthetically or as well on the management of the soft tissue and bone.
Yeah, and it's a big problem in implant training because these dentists are going outside the country, so they'll go to Mexico or Dominican Republic, and they'll place a whole bunch of implants, but they don't ever get to see them again. So I mean,
exactly, that's correct, and they don't get to see them again, and they the technique at the end is the industry of dentistry. That's what happened when you go to a big meeting. They pretty much focus on the technique, on how to do things, more than the complications that you deal after.
What I like about you is, so you go to these major meetings, and when it gets to implants, they want to talk about all these big, sexy, all-on-4 cases and these roundhouses and all that stuff. But, that's lifestyles of the rich and famous. What's far more beneficial to the most Americans is what you're doing with treating edentulous ridges, implant-supported dentures. Talk about, do you agree?
Oh, yes. Well, I do a lot of cases for the edentulous patients, and it's getting very. I started more into aesthetics, and for many years, and it was because I was very frustrated for many years on the edentulous patients because they were not happy. They were very frustrated, and then when we came up with the all-on-4 screw-retained prosthesis, it's a great solution, but to be honest, it has a lot of complications. It has a lot of failures, a lot of difficulties to maintain, and so it's been really rewarding to find new techniques where when we can have the patient wearing something fixed, but at the end of the day they can remove and clean and to have a spare one just in case something breaks. So I'm always concerned. I'm always, when I treat somebody, I'm always thinking of what would happen, what would be the best case scenario, and what would be the contingency plan when something fails. And that has been the approach, and we have been developing better techniques and more reliable techniques and more affordable type of prosthesis for the edentulous patient nowadays.
Well, you know, Clear Choice is the mothership of all the all-on-4s, and they're only doing like 18,000 arches a year. In a country that has 324 million people, I would just think that there's probably I mean, by age 64, 10% of America is edentulous, and by 74, 20% of America is edentulous. So that just means an implant-supported denture has got to be the biggest part of the implant market.
That is correct. That is correct. There's a statistical number in 2012 that 35 million edentulous patients in the United States, and that is going to reach 40 million by the year 2020. So yes, definitely, we are definitely not taking care of not even half of the population that is edentulous. And normally, before the implant supported type of prosthesis, it was just dentures. And as we know, that really doesn't take care of the problem. That doesn't take care of the emotional portion of the patient, the function, how they eat. The chewing efficiency is not a proper one. So implants are very important for the edentulous patient, and to come and to come up with better solutions and more affordable solutions. That's one of my goals and the goals of my team.
You know, podcasters are young. I always ask my homies, send me an email, shoot me an email, howard@dentaltown.com, and tell me your name, how old you are, things like that. I'd love to get demographic feedback, but it sounds like about 25% of them are in dental school right now listening to you, and the other 75% are under 30. So they come out of school, they've maybe never even done a lower denture, and they certainly haven't placed an implant. How do you get at, and then say they're going back to, you know, real world America where there's more poor than rich. How does she learn how to do an implant retained lower denture?
Wow. Well, first of all,
how would you start her out on that journey?
First of all, the first thing is you need to know how to make a denture, because that's the beginning. That's where you set up the teeth on the face. You need to know about a smile design based on face, on the face design. You know, integrate the teeth with the rest of the face. And there are many different courses to do that. You know, the very popular DSD, Digital Smile Design by Kristen Coachman, when finally integrates in a digital way all the features of the face to set up the teeth on the right position. So that's a good start. You know, use technology is making things a lot easier and better to restore the edentulous patient. But going back to your question, the number one thing is you need to know how to make a denture. If you don't know how to make a denture, then forget about doing an overdenture with implants. There's no way. That's the first thing that you need to do. To do the denture, and based on the denture, have the plan of where to place the implants, how many implants, and the type of prosthesis needed for every particular case. But we have to start with a diagnostic portion, which is a denture.
So you would build the complete denture first and try to get them happy in the denture.
Yes.
Would you have designed the implants first before you even started the denture?
No, it's first to set up the teeth, not necessarily to have a full completed denture, all process all the way to the end, but at least the setup of the teeth, where you can have a cone beam CT scan done with that setting, knowing exactly where the teeth are going to be, because then you need some restorative space. To get that restorative space, you need to know where the teeth are, and based on that, with the computer, we can create virtually it tells how much bone do we have to remove to create that restorative space, how much bone we have to graft to get the implants in the right spot. So everything has to be how do you say it? It's a reverse engineering. You have to start with the end in mind, and then from there you design your case so for the prosthesis to function, and not the other way around. Unfortunately, we get a lot of cases where the implants are already in place, and we have to do really heroic things to make this type of prosthesis work. Because of that as well, we have to have protocols that are a little bit more forgiving on the position of the implants. So that's important too, but ideally always is starting with the end in mind, and always starting with setting up the teeth in the right position based on the face.
What is the sweet spot? Is your average implant supported edentulous person a grandma and grandpa? I mean, is it usually someone over 65?
Not really. I would say it varies a lot. Of course, we have probably average would be on the 60s, and that creates a bigger concern on how long that type of prosthesis is going to last, and how much maintenance you're going to need for the rest of your life. But it's not very uncommon that we have patients with abuse of drugs where they have to early in life, even early 40s, early 30s, that we have to actually extract all the teeth. But yeah, I would say that an average of there are 60-year-old patients, 60-year-old in the 60s, late 60s.
And how many implants would your average implant retain denture? How many would you use?
Well,
and would they mostly be on the lower, or are you still using them on the uppers?
Do both. I think that to get the 100% of quality of life, is to have something fixed. It's something that doesn't rock, doesn't move. And to get that goal, we need at least 4 implants in the mandible and at least 4 implants in the maxilla. Ideally, at least 4 implants in the mandible and 6 implants in the maxilla, and that's just a baseline. Because every patient is different, the quality of bone has to do a lot with it, and sometimes we have to over-engineer because of the quality of bone, so we have to go on 8 implants. But I'm just talking about average. Average probably is about 4 implants in the mandible, 6 implants in the maxilla for a good success rate, and that's for a fixed type of prosthesis. Implant supported, when it's 100% implant supported. Then we have the other kind where it's assisted by implants, where you still have soft tissue and bone support, and then you assist the prosthesis in retention, like the 2 implants with an overdenture for the mandible. And that's a wonderful treatment, and that takes care of a lot of people that don't have the means to spend more than that in a more complex type of prosthesis. The maxilla, that's another animal. That, in my opinion, and it's just personal, just opinion. I think an implant-assisted prosthesis is not a good option unless the implants are splintered together in the maxilla. It's a completely different animal. However, for the mandible, as we know, dentures by itself, they work a lot better in the maxilla than the mandible. So with 2 implants in the mandible, it just makes a huge difference for the patient's quality of life.
I mean, when I started getting into placing implants way back in the day, I had so many denture patients that I was saying, oh, I'll do them free because I want a teaching case. I want a learning case. I'm just getting into this, and they're still my patients. and that say, I mean, 30 years later, they're still there, and they're saying, no, I've never had a problem with my dentures, period. I mean, so I got a lot of those patients that I couldn't even do the case for free. But the rest of the denture patients, it seems like almost none of them have problems with the upper denture. It's almost always the lower denture. But I want to go back to the $1,000,000 question. If I came to you and you did an all-on-4 fixed on my mandible, what would that cost versus if you did an overdenture on 2 implants? I mean, what is the cost difference in New Orleans for you?
It depends. It depends on the type of prosthesis and how many implants. But let's go back to the basics of 2 implants. All right, 2 implants is the cost of the implants, and I think that the average cost of the surgical part is about $2,000 per implant. And then is the type of attachment. The most popular one nowadays probably is a locator type of attachment, a studded abutment, or the O-ring, and that one, it varies. It could be, I don't know, like a couple $100, $300, $400 per attachment in the denture. So, you're talking about the price of the denture, which an average nationally is about $2,500 for a denture. And you're talking about probably $800 to $1,000 for the attachments, plus $2,000 per implant for the surgical portion of it.
So just ballpark, what would the total be for a denture on the mandible on 2 implants versus fixed on the mandible on 4 implants? I mean, just ballpark on an average.
Oh, well, it's a big difference. Well, the type of prosthesis that I'm using, that is a telescopic fixed prosthesis instead of the screw retain, I'm going to give you the 3 ones, the 3 types that I do, okay?
Okay.
Locator-wise, let's say the prosthetics. I'm just going to talk about prosthetics, okay?
Okay.
To keep it simple. Okay, so we know that the implants surgical is $2,000 each. So let's put that on a side. Now the prosthetics in overdenture with 2 locators, it's about $4,000. Okay, if we go to 4 implants in a telescopic fixed prosthesis, that's about $8,000. It's about $8,000 to $10,000. But the $10,000 include a spare one that is made of just plastic. Okay, and then when we go to a screw retain all-on-4 type of prosthesis, we're talking about $15,000 about average.
15,000.
Yes, for the prosthetics. It's about that, yeah. So
it's a big difference in price. I mean, it's why GM sells a low-cost Chevy, then a Pontiac, then an Olds, then a Buick, then a Cadillac. So GM has 5 price points, but you have 3 price points.
Yeah, so it goes from denture, let's say $2,500, with overdenture with 2 implants, $5,000. When you go to 4 implants fixed detachable, let's put it that way, $10,000, and for the screw retain all-on-4 is $15,000.
And would you? So do you obviously? So every time you do, so what is the percent of the market there in your practice? I mean, is it like 25% each one of those 4 price points, or is it heavily weighted towards the $5,000 overdenture? I mean, how many $5,000 overdentures would you do compared to one $15,000 screwed all-on-4?
Most of the time, I do to tell you the truth, personally, I do very little of 2 implants overdenture. I can, in general, patients find a way, if they already are able to pay $5,000, to go and to go the extra mile with $3,000 more and get something fixed that is completely, doesn't move at all, that is 100% implant supported. When you talk to patients and really give them good education and good explanations in what is one versus the other, in general, the patients make the extra effort to go for the one that is fixed.
So if they're going to go all the way to the dance for $5,000, they're going to find a way to go even further to 10 or 15.
That's correct, and I think, and like I was saying before, the technique that I use now, I'm no longer using or really rarely I use a screw retain. I use more fixed detachable, just for the maintenance issue, because it's not only what you pay. It's again, it's always thinking of how much is going to be when it fails, and how much is going to be the repairs, and how much is going to be the maintenance, and how often you're going to need maintenance, and which one is easier. So when it comes to that, then it's not only $15,000, it's how much more they're going to pay through the years, because those teeth are not going to last forever. The structure might last forever, but not the teeth. So I always think of what is the worst thing could happen with this type of prosthesis. So with the one that we're doing at $10,000, it's cheaper on the maintenance side as well, and you have a fixed prosthesis that is more maintainable and more cleanable than the other type of screw retain prosthesis.
So the $15,000 one is the best, you're saying?
The $10,000.
The $10,000 one is the best in your opinion? Wow, that is very interesting. Some people are saying that in the United States, at 60 months, 20% of implants have Peri Implantitis. Do you agree with that number? Is that what you're seeing in the field?
Well, it's just, I agree with, if you put in the bunch, if you put in the bag, everybody. If we put in the bag everybody, the trained dentist and the not very well trained dentist, all together, I would say yes. Okay, that number is a lot better when all the right training and the right follow up and the right technique and the right. I mean, it requires a lot of knowledge. It requires a lot of training. It requires a lot of CE. Every year there's something new. I mean, before these numbers as well, they were related with excess cement. Now we know more about excess cement than before. So we are avoiding that type of problems nowadays. It depends on the implant system as well. It depends on the surgical technique. It depends on so many things. It depends on how you work with your team. And having a team, it's very different, the results that you get when you work when you don't work in an interdisciplinary way than when you work separately. When you work in an interdisciplinary way, things work a lot better because you are using the brains of specialists, different specialists that work together with the same treatment plan, versus having separate entities working in a separate way. And that's when problems arise. But I would agree with you, because it's not very common when dentists work in an interdisciplinary way.
Yeah, and there's going to be a lot less of it, because when these kids are coming out of school, $350,000, they can't refer out molar endo and perio surgeries and crumbs to crowns. I think the level of debt is going to put extreme downward pressures on interdisciplinary care. Do you agree or disagree?
That's correct. I agree 100% with you. It's outrageous how much debt they graduate with, and they have to do something. They have to start making money out of school right away, and it's incredible. And yes, that really makes it different on what you should do. However, I would say you always have to make your decisions not based on money and just based on what is best for the patient. And we all know that the best for the patient is to work as a team. It might require a little more training, a little more effort, but at the end, actually, it's gonna be an investment, because at the end you're gonna be a better clinician where you're gonna have less problems, because as you know, problems in the long term they're gonna take a lot of your money, and if you don't plan properly, you're gonna have way more problems than if you do it in the right way. It sounds like at the beginning it's a larger investment when you work with different specialists, but at the end, in the long term, that's actually more profitable and having less problems in the future.
Hilt Tatum, I did a podcast with him, and he said something very profound. He thought a lot of the perio implantitis is because the surgery wasn't done right and they didn't handle the tissue correctly, so that attached gingiva was all sewn back around, and that he sees all these Peri Implantitis, and he just thinks the implant wasn't an attached gingiva, and that was it started out as a failure. Do you see that?
I wouldn't say I guess it's easy to point fingers, and perhaps if you ask a surgeon, periodontist or oral surgeon, if you ask what's the biggest reason for periodontitis, they're going to tell you, oh, it's the design of the prosthesis, and it's because of the cement, and it's because of this and that from the prosthetic side. And if you ask the restorative dentist, it's easier to say, well, it's because they didn't perform the surgery. They were not careful enough on the drilling protocol. They overheated the bone. They didn't place the implant at the right level. Stuff like that. You always try to point fingers, and at the end, it's all of the above. And at the end, there's a third entity, and it is the patient compliance. There's so many things, and as you know, many of these patients, especially the edentulous patients, most of them, they lost their teeth in the first place for a reason, because they were not good maintaining their teeth. They were really poor hygiene, and at the end, we have a big responsibility on educating these patients and train these patients to change those habits. But it takes a lot of effort. First on our side to train them, and on their side to really comply to that. But at the end, what's easier? To floss your own teeth in between your own teeth, or to go underneath a full arch prosthesis with implants with a super floss and everything. That takes 15 minutes versus 2 minutes that used to take you to do on your own teeth. You think patients that were not taking care of their own teeth for 1 minute or 2 minutes a day, now they're going to do 15, 30 minutes a day? That's another problem. So it's all the above. Yes, you need to have a great surgical technique. Yes, you have to understand biomechanics. You have to understand the science where cleaning is easier. And then you have to invest a lot of time and effort on training the patients for them to maintain the prosthesis.
That sounds so great. And dentists need to do a better job of letting them know that these implants don't last forever. Like I've noticed that every one of my patients that goes in and gets a total hip or a total knee replacement, I always say, well, did the doc say how long that would last? And they always have a number. They always say, yeah, doc said, should be able to get 5 to 10 years out of a hip. But they never walk out of there and think, oh, I got a brand new hip. I'm good to go for life. And I watched this TED Talk of a psychologist, and she was saying that it's considered over-the-top success if you can change like 6% of people's behavior in like a year period. Like only 1% of smokers quit. It's considered a miracle if you could get like 6% of a population of couch potatoes to actually change your behavior and join a gym. So you're right. These people that ended up losing all their teeth for a myriad of reasons, to think that you're going to get more than 6% of these people to change their home care, their lifestyle, all that stuff. So you just got to start planting seeds that a hip, a knee, an implant in your jaw, it's a success if they last 5 to 10 years. How long are you telling them? Is 5 to 10 years about your window, or do you compare it to a hip and a knee?
I think it's very dangerous to say any number.
You say what?
I know to tell them a number, I think is very, you're putting yourself in a really tough position. Because, like I said, it depends on many, many factors. And it's just like kind of taking away their responsibility on maintenance. So I tell them, especially on the edentulous patient, listen, you're here with no teeth. And the implants are not better than teeth. It's a good option when you don't have teeth. It's not a replacement for teeth. Teeth, they were designed to last forever in your mouth, and they're not in your mouth anymore. So with implants now, you have to be way more careful. So it means that it's not enough to go back to spend the time that you would spend cleaning your own teeth. Now is even more that you have to spend on the maintenance, on the follow-ups. And so I never give them really a number because it varies so much. These type of prostheses, the all on four, the plastic, the teeth were designed to function in dentures, not to function with implants on a fixed prosthesis. So the teeth are going to break at some point. And how often they're going to break, it just varies so much. Sometimes it happens 2 months after they break a tooth. Sometimes it's 2 years after. So if I tell them, I always tell them, these teeth are going to break. And perhaps on the first year you have this kind of warranty, but at the end, we're going to have a maintenance plan for the rest of the years. And pretty much I always talk to them like in terms of a car. Just the analogy that you presented before is perfect. And I always tell them, what you asking me is just asking me if your car is going to last forever. You're buying a car, and you're telling me if that car is going to last forever. If you buy a car, as soon as you get out of here, you can have an accident and you can break the car. Or if nothing happens, eventually you're going to have to change the tires. Eventually you're going to have to change the timing belt. So I always talk to them in those terms. It's like nothing lasts forever, and everything is gonna need maintenance. So I cannot guarantee you. I really never guarantee anything. I always give you a period of grace, a grace period of a year when whatever breaks on that first year I cover at no charge. But after that they have to be responsible for the maintenance.
It's tough when you go around the world because so much of implant training is driven by the manufacturer. So a lot of them you almost really got to decide what implant system that you want to go with before you start taking the courses. What is your short list of implant systems? Make it easy for her. She doesn't want to go out there. I mean, there's literally, you're not going to believe this, but there's over 700 different dental implant systems around the world. In fact, Italy, just the country of Italy, has like over 75. Just crazy over there in Europe. She doesn't want to research 750 different companies. What implant system would you recommend that she decides to use? Because that's going to be where a lot of the courses and training material in her city is going to be with.
I would select a serious company that has been in the market for at least 10 years, okay? Because there are many companies that just disappear. And as we know, like what we keep saying, maintenance is a factor. And when you have an implant that perhaps is very cheap, and for you to start implant dentistry, and perhaps it works, perhaps it integrates well, but at some point something's going to break, an abutment, a screw, or something. And if the company is no longer in the market, then you're in trouble. All right, and then you have to strike the implant. So again, it's always thinking about the contingency plan. So that's one thing, that a company that has been in the market for more than 10 years, a company that invests money on research, a company that really has a lot of, and those companies in general are not going to be the cheapest implants, because those implants, they have to invest a lot of money on research. I'm not a fan, and it's just my opinion, but I'm not a fan of the Mickey Mouse implants, the replicas that came out at half the price of the original design, right? Quality control, you cannot tell. Nobody can tell just by watching an implant and seeing an implant if the surface is clean or not. That's quality control, and quality control is expensive. So the main companies that have that research background, those are the companies that I would recommend to use for your implants. It's just every time that you select an implant, just think that what implant would you select if that implant you're going to put in your mouth? That's the thing. Or you're going to put that implant in your mother's mouth or your son or your kid's mouth. Okay, that's how you select your implant. And there's a handful of companies that they have CE courses, that they have serious CE courses, that they have really good background. They have long-term in the market. They're implants that have been in the market for more than 30 years. that stay there, and they're been there for more than 30 years for a reason. Nobel, Astra, Ankylos, Zimmer, Biomet, BioHorizon, Straumann. Those are the main companies that I can come up with that I've been working. I'm very fortunate that being in academia, I get to work with all of them.
So you would put every one of those in your mouth?
Any of those, yes.
Nobel, Astra, Ankylos, Zimmer Biomet, BioHorizon, and Straumann?
Yes.
Okay,
yes.
well that narrows it down from 750 to 6. That's a nice condensing.
That's nice condensing, yes.
How would you guide her to go from 6 to 1? What should she be thinking about?
Well, it depends. There are certain implants that preserve the bone better than others. There are certain implants that are more robust than others. It depends on the area where you're working at. For example, Astra is a very good, robust implant that has been proven in the literature that preserves bone. It's a good design, and it works well. The other thing I forgot to mention, the customer support. That's very important. And that's the other reason I select the companies that have a rep in the area that is gonna assist you anytime you need something. I know of other great implants in the market in Europe that they're wonderful. That unfortunately, because they're not so big, they don't have support in every location. So that's another thing. You need to have good service and good customer service and good support in the area. That's why that's an arrow to those companies that we get the support immediately.
Yeah, I like your list of 6, and I also believe strongly. You talk about when you're designing implant cases, they're built on contingency, and I think the best implant training is by your own periodontist in your own zip code. So if your periodontist up the street or your oral surgeon is using an implant system, and they're teaching you how to place implants, and say you place an implant system, and then 5 years later something needs to be done to it, and you need to refer to a periodontist oral surgeon, they're familiar with that system. So it seems like when I ever meet a dentist who passed the 100 mark, they've got 100 implants in the jaw, they always are very close to a rep. I never meet that dentist who goes from 0 to 100 buying all of his implants online. He always has an in his backyard relationship with a rep, and more times than not, at least 2/3 of them have a relationship with that rep has introduced that dentist to other dentists place those implants, whether they be periodontists or implantologists, whatever. So they have a human capital in the field, and that's a big part of the equation.
Yes, that is correct. And me being a prosthodontist, it's actually more important the restorative options, because all the names that I gave you, I think that the implants are pretty damn good. All right, the implant itself is going to integrate. The success rate, they have really good research, they have really good support, but it's also important to select the implant system that is going to be more friendly to you prosthetically, that is going to be versatile, that is going to give you options, that is going to be supported by the companies that make custom titanium CAD/CAM abutments. I want a system that I can just make an impression and I can digitally have a CAD/CAM abutment. And if you have an implant that is not very popular, they're not going to have that option.
Go ahead.
So in other words, I do have the luxury of being a prosthodontist that when I work with my specialist, they actually ask me, so what implant do you want me to work with you? And because the prosthetics it's a really, really important part. At the end, the implant in general, the companies, the names that I gave you, at the end, the surgical technique is going to be very similar. is going to be very similar. So it's not going to be a big difference for the surgeon to place one versus another. But for the prosthetics, it can vary a lot, and it depends on where you are focused on in your practice.
Explain this to us, sure. DENTSPLY owns Astra and Ankylose, and
Yes.
Danaher owns Noble Biocare and Implants Direct. Why do you think big old DENTSPLY Sirona would want to own Astra, two implant systems, Astra and Ankylose? And why do you think Danaher, through Cybron, wants to own Noble Biocare and Implants Direct? Why do you think?
Well, they have those implants because they bought the company because it was a good option and it was a good implant. These companies are not where they are for nothing. They do their research, and they're not going to select an implant that is not going to work. So they do their research, and if it's not going to work, they're not going to buy it. So these big corporations buy these companies because they're good implants and been proven to work very well in the market.
Well, you mentioned both the DENTSPLYs, Astra and Ankylose, but on Danaher, you just mentioned No Biocare. Does Implants Direct make that list?
Implant Direct was born as doing replicas of other implants in the market. Okay, I have not been, and probably it's because I was in academia that we didn't have access to those implants. I have nothing to say about them because I have never worked with them. Doesn't mean that they don't work, but to hear that now it's become a part with the Nobel family, that gives me a good feeling about them.
Right on.
For sure.
You also you're a prosthodontist, but you use orthodontics in some of your implant cases. What is
That's correct.
what makes you put on your and that's what I love about dentists going out and getting their FAGD, their MAGD, where they have to learn different areas of dentistry. I mean, everybody should do an implant surgery to understand implants better, even if you don't place them the rest of your life. And ortho, when do you put on your orthodontic hat in an implant case?
Well, I started. It was really back in the days when I had my surgical training in my practice before I moved to New Orleans and do my pros residency. In my practice, I was in a practice with my dad and my brother, and my dad was a prosthodontist, and I was the one placing the implants in the practice.
And where was this practice at?
It was in Mexico City. That was back in Mexico City.
So your dad and brother are practicing dentists in Mexico City?
That's correct.
Oh my gosh! So
my dental education I started when I was 6 years old, going to my dad's office, and I was a weird kid because instead of playing soccer outside with the kids like every other guy, I was doing wax-ups, P.K. Thomas technique in my dad's lab, and then casting stuff and everything. So I was born in dentistry, but anyway, later in life, I got the surgical training, and I was placing the implants in the practice. And my brother is an orthodontist, and so in the practice as well, I have an endodontist.
Your dad was a general dentist?
My dad was a general dentist with not a formal post-grad prosthodontic training. However, he was trained early in the 70s with all the naturological school here in the United States, with P.K. Thomas, Lloyd Nealer, Raymond Contino. He was trained with them, and he was only doing pros. He was doing complete dentures. He was doing full mouth cases. He was dedicating his practice to prosthodontics. So I call him a prosthodontist because that's what he was doing. Didn't have the certificate for prosthodontist, but he was at some point the president of the Prosthodontic Society in Mexico City. So it was funny. But anyway, early in life, my brother was really impressed with the Atlanta Team Atlanta and working interdisciplinary with Salama Brothers, with Goldstein and Dr. Garber, and so with him really early in my dental career, I started working with interdisciplinary dentistry. So we were doing a lot of cases together where we were moving teeth to create bone. We were using implants to move teeth around. So early in life, I really believe a lot on orthodontics. I love orthodontics. That's my other passion other than prosthodontics. And when I came here in the residency, sometimes there were not too many people that I could work with on that kind of approach. So in my residency, I was very fortunate that we had training as well. Once a week, we were having training with the ortho department. So we were learning how to place how to make minor movements and everything. So I started getting into doing a lot of force eruption to create bone and soft tissue and be more predictable on the aesthetic result on implant dentistry.
So what made you leave Mexico City, which is just 25 million people? That town's got more class and culture and things to do, and your dad's there and your brother's there. They say you only leave your country for a job or a woman. So I'm assuming that there was a hot little girl in New Orleans that caught your eye. Is that what it was?
No, that's not what it was. I ended up, marrying somebody here, but at the beginning, she was not in the picture. I didn't know her yet. I didn't know anything about her yet. My plan was my dad as a practitioner prosthodontist, his dream always was for me to be a prosthodontist. So he was doing supporting me in every way possible for me to get my certification. When I was having a great practice, really successful practice in Mexico, and then I got to see Dr. Jerry Shish in a lecture together with Dr. Michael Block. And when I saw that lecture, I felt like I needed to know more. And that's when I got convinced that I needed to move to New Orleans, because that's where Dr. Shish was in the Department of Prosthodontics. So I moved to New Orleans, not to the United States. I was very selective. I wanted to be here at LSU in New Orleans. So my plan was to come here. For our plan, my dad and me and my plan was to come here, study 3 years, and go back and practice with my dad and my brother. That was the plan. It happens that after a year moving to New Orleans, I just fell in love with New Orleans. In this case, it was love, not for a woman. It was love for a great city. And I love my school and LSU. I was very happy here. And after the first year, I realized that I wanted to stay here in New Orleans. And even though it was very painful for my dad to see me leaving, because he really wanted to have, he always had that dream to work together. But at the end, he was very happy that I live here. It was a fun place, a quiet place, in comparison to Mexico City, with still great food. As you know, New Orleans has, I have to say, probably the best food I have tried in the United States. So that was the other thing, the food, the people. And then the last thing that made me stay, it was when Katrina hit New Orleans, the hurricane, and to see the heart and the courage of the people of New Orleans and my beloved saints, my New Orleans saints, then it was the whole package. After that, when I finished my residency, that's when I met my wife, which she's not from New Orleans, she's from New Jersey. But I met her here because she was doing dental school here in New Orleans. And that's how we met. And in her case, I have to say, she's going to kill me for saying this, but in her case, it was me the reason why she decided to stay in New Orleans.
How do you pronounce that? Siche?
Shish.
How's he doing?
He is doing great. Great teacher, great mentor. He is in Augusta, Georgia. And he, as you know, he lectures pretty much every week, all over the world and all over the country, and he's doing fantastic. I get to be in touch with him constantly. He has been a great mentor in life and in my profession, and always taking care of me and learn. And I owe him a lot of what I know in dentistry to him, of course.
That is so cool. Yeah, next time you talk to him, tell him I've been trying to get him on the show for 2 years. Tell him I've done 1,000 shows, and he was one of my first 5 or 6 that I tried to email. So I know he's busier than a one-armed paper hanger. But if he ever has an hour, tell him I'll do it 24 hours a day, 7 days, and I'll do it in the middle of the night.
I will. I will definitely let him know. I know him very well. An hour is a long time for him. I can tell you that. He's a really busy man. He's very committed with the profession, and my God, there's a reason why he's so renowned, and there's a reason why he's so good, and there's a reason why he changed the way we do things in aesthetics, and it's because he's 100% committed to this business, and that's why he really doesn't really have a lot of time to have interviews. I know him very well, and even for me, I call him. He always returns my calls, but probably a couple of days after, and mostly is when he's traveling, when he's time in the airport or something. That's when he calls me, and but it's hard to get him.
He's an amazing man. And I'm also surprised that when I asked which implant system you use, that you didn't go with Straumann for one obvious reason. Your name is Marco, and the CEO of Straumann is Marco Godola. I figured the Marcos would just stick together. Did you have you ever met him, Marco Godola? Straumann actually.
I don't have the pleasure to know him. Early in life, I had two options. When I just first started in Mexico City, placing implants, I started placing implants with 3i. That's the system. But I had the option. I had training with Straumann and with 3i, and at the time, it was when Straumann was really hard on tissue level and not bone level, and that's why that's what makes my decision to move it and get trained with 3i and with the system. Not that it was not a good system; it was just a little more complex from my understanding at the time.
Yeah, and then 3i got bought by they all rolled up into Zimmer, right? It was Zimmer swallowed up 3.
Yes.
3i got swallowed by Biomet, or
Yes, Biomet got sold by Zimmer.
Zimmer, and then Zimmer got swallowed by Biomet or something. But yeah, a lot of mergers and acquisitions in that industry in there.
Absolutely, yes, there's a lot of that.
So, aesthetics on implants, ceramic materials for restorations and implant abutments, or are you doing porcelain fused to metal still? Is there, when are you? What is your ceramic materials?
Okay, for the restoration, for aesthetics, no, I don't use PFM anymore at all. It has been probably 6 years.
That is
since
one
the last
thing
time
I never saw coming when I was in dental school, that the PFM would go the way of the dinosaur. I mean, that came out of left field.
I lecture a lot on material selection. I do because it's very, very. The first time I got invited to talk about that, it was for an oral surgery group for the AMOS. They asked me to talk about material selection, and I was, are you kidding me? I'm gonna bore them to death. They're gonna die with my lecture. So I need to come up with, that Einstein used to say, if you don't explain it clearly in a simple way, it's because you don't understand it at all, or enough. So I had to really merge myself into it to really explain in a simple way. And in that, it was during that time that I realized that PFM was no longer an option. And that things are changing, that back in the days it was easy to select ceramic materials in the 80s. It was just PFM. That's it. Right? It was the only option for aesthetics. It had their time and everything, but we have better materials now that are reliable, that are durable, that are going to last as long.
But one thing I want to clarify, you said that the only option you had early in your career for aesthetics was a PFM. But it's funny because, Ryan and I, tomorrow we're on a plane to Toronto, Canada. We were in we're usually lecturing in 5 continents a year. And gold in the anterior, it's only a taboo in about 20 countries. I mean, they love gold on their front teeth. I don't care if it's a full gold crown. There's so much in Africa, Asia, and Latin America and Central America where the most rocking hot woman in the bar might have a gold central incisor or a lateral.
Oh yeah, and that's pretty much fashion. When I was saying aesthetics, I was probably just kind of saying mimicking
Yeah,
nature,
yeah.
and that would be the concept, my concept of aesthetics.
Is gold?
But I completely understand that fashion, and there's a trend of fashion of having gold in the front, even jewelry bonded to the teeth.
Gold teeth is more common in anterior teeth on pretty ladies in Mexico City than New Orleans, wouldn't you say?
Yes, I would say so. Even though New Orleans, there's a lot of people, but
Yeah.
the trend is changing. We do have a lot of patients that come with a gold window or a gold tooth
Yeah.
that they want to replace. But you still get from time to time even the denture patient that they want to have in their denture a gold tooth.
I know, and I've had this ethics problem. I get it about every I don't know, maybe every 5 to 6, 7 years. Some young beautiful girl wants me to file down a completely perfect anterior tooth and make a gold crown, and I'm just like, you know what? I'm sorry. You're a
Yep.
kid. I raised 4 kids. You're all excited about this new gold tooth or this tattoo, but are you going to be excited about this gold tooth and a tattoo 5 years from now? And I'm sure you can
That
find anyone to do it, but it's just not going to be me. So I'm thinking, is it an
that's
impulsive buy? Go take a chill
that's
pill.
exactly That's exactly my answer. And you're absolutely right. You think it's cool now, but I'm not going to do something that is irreversible. I can do anything that they want as long as it's reversible.
Right.
Okay? So, for example, I have a friend here that is a faculty that he's going to give a table clinic at the AGD on jewelry on teeth, on having, the bonding technique to put some jewelry, but it's always reversible, you know? As long as it's not invasive, as long as it's not going to damage the soft tissue and it's reversible, I can do that. But anything that is reversible with gold, for example, like you said, I said, no, you can find somebody else to do it for you.
Yeah. Exactly. My gosh, I can't believe we went over an hour. That was the fastest hour ever. I could talk to you for 40 days and 40 nights. I sent you that my podcast on Marco because I think you should take another look at Straumann since you have the same name with him. You guys might be buddies for the rest of your life. But hey, any chance we could ever get you to create an online CE course for us on Dental Town? We put up 400 courses, and they're coming up on 1 million views because these millennials would rather just watch an hour course on their iPad or on their iPhone instead of traveling across the country. And when Ryan and I are in Asia and Africa and South America, those dentists are so grateful. There was a dentist in Tanzania, and she was crying. She goes, I could never afford to fly to the United States to see any of these lectures. She goes, I couldn't even afford
Mm-hmm.
the plane ticket. And I'm watching them in Tanzania. And but I'd sure love to get a course from you someday. I know you're busy as heck too, but if you ever have time, we sure love to have an online CE course for you.
Oh, absolutely. Let's talk about that. And I really love the 20 minutes type of lecture when you can really give them something to take home and go in depth in a very simple concept and go in depth for 20 minutes. Because as you say, the new generation, the millennials, they have a very short span. They cannot spend too much time on a concept. So there's studies showing that after 20 minutes, that's it. You don't have their attention anymore.
And cut it in half if they're on caffeine. No,
Yes.
I have a teacher friend, but anyway, the research, are those your two daughters in your background?
These are my twins, and this is my boy and my girl.
Oh my God, they're so adorable. How old are they?
They just turned 4 in October, and they're my everything. Let's put it that way.
Yeah, and I was reading, there's a lot of research that's going to change their education world. There's a lot of research that says that you almost can't, children can't induce long term memory till like 9 or 10 in the morning. So getting them up at 7 when they're tired and dropping them off at school when they're groggy, they just sit there in a fog and they don't even come alive till like 10 o'clock. And then when you're teaching them a concept, you're exactly right. 15 minutes max to
Mhm.
get them to listen to you and focus, and cut it in half if they drink a Mountain Dew on the way to school. And that's why
Yep.
I think our online see, because it's kind of sometimes it's overwhelming to say, gosh, do I want to block off Friday and go to a course from 8 to 5? I mean, and it's like, oh my God. But if you said, hey, how about instead of 8 to 5, just 1 hour, and you can watch it on your iPad. And if they got to go to the bathroom, they can pause it or whatever, or rewatch it. So I think it's really the future.
And I do believe in online education. I still believe, as you are traveling, I still believe in the human contact. And I really enjoy when I lecture and I have a full day lecture. And I use pretty much the same concept of every 15 minutes, I change the dynamics. Every 15 minutes, I come up with music or a joke or something and change the dynamics and move to a next topic. And I can spend 8 hours like that, and it works if you go 15 minutes at a time.
Well, that is amazing. You have dentistry in your blood, from your dad to your brother, and I wonder if one of those twins will be a dentist, a prosthodontist.
I don't know, because it's built in my DNA. I breathe, I eat, and I live dentistry. And that's gonna be, it's my life. For some people, it's not their life. For me, it's my life.
Well, I'll tell you what, it was a huge honor to have you come on the show today. It was a privilege to podcast you. Thanks so much for coming on my show today.
Oh, thank you so much. It was great to meet you and to spend time with you. Thank you so much for the invitation. The honor is all mine.
Now, have a rockin' hot day and give those two kids a kiss from Grandpa Howie.
Okay, I will. Take care. Bye-bye.